Please welcome Amanda Hale, Vice President of Partnerships at The Atlantic.
Hi everyone, I'm Amanda Hale, Vice President of Partnerships here at The Atlantic, and I am so excited that you've joined us for this important conversation about AI and the future of healthcare. From disease detection to drug discovery, artificial intelligence is revolutionizing healthcare. As we navigate the future of healthcare technology, what guardrails are needed to protect both patients and clinicians? This forum will explore the real-world applications of health AI, as well as the challenges and the opportunities that it presents. We'll discuss the life-saving applications of AI, innovations in personalized healthcare, and the path to establishing trust amongst patients and physicians as we traverse this giant leap in healthcare technology. Before we begin, I want to thank our underwriter, Evernorth, for their support of The Atlantic's journalism. Please silence your cell phones, but keep them handy. If you hear something that resonates with you, please post it to social media using the hashtag TAF24. Now, let's begin our conversation.
For a conversation on the life-saving potential of AI, please welcome Dr. Velculescu, Co-Director of Cancer Genetics and Epigenetics at Johns Hopkins Kimmel Cancer Center and founder of Delphi Diagnostics. Suchi Saria, founder and CEO of Bayesian Health and professor at Johns Hopkins University. And Zhavoronkov, founder and CEO of Insilico Medicine, with Bhumika Tharoor, managing editor at The Atlantic.
Hello, welcome. So many interesting things to discuss today, so let's jump right in, but I just want to make a note that we'll make time for a Q&A at the end of the session. Thank you all for joining. I want to start broad, and when we're thinking about the future of AI and healthcare, let's start with the provider's perspective, and I'm curious what, in the future, and let's say 10 years in the future, what's going to change about how providers offer care? And I think a second part of that conversation, I'm curious to know, what will medical school look like in a world where we have more AI integration? And are we going to think differently about how we're training providers? And if you could please start for us.
Sure. No, and thanks for that question. You know, we live in an incredible time, I think, when the fusion of AI and medicine is going to change things in a way that's radically different, more so than I think in the history of medicine. I think what we're going to have in the near future, frankly, is going to be a number of different tools that are AI derived that are going to help us in ways that are almost unimaginable. As an example, we've been working on a blood test that uses pieces of DNA in the blood and uses AI to analyze those and to detect where cancer is coming from. So that alone could be something that a practitioner could utilize to easily tell a patient whether or not they are likely to have cancer and then initiate follow-up testing, again, in a way that's completely unimaginable today. Just one quick thing, I don't think physicians are going to disappear. I think there's this concern that AI will totally, make them all go away. That is not going to happen. There's too much information in the history of medicine and training that really is best kept through that educational system. There aren't enough patients and conditions to train an AI system de novo to do that. So I think that's going to be intact, but there'll be a lot of new tools that I think practitioners can utilize to help patients.
Thank you. Yeah.
I think to just build on that answer, right? So I think look at the way we deliver care today. Literally all of our workflows were invented pre-digital, right? Like, you go into a doctor's office, you take notes, you think about it, you prescribe something. And what's changed in the last 10 years is this crazy explosion of the amount of data we're recording, the rate at which research is getting done because of AI and other disciplines, like our discovery rate is changing. And so the question is, and our patients are getting more complex, so the load we put on the health system has gone way up. So the question is, how do we make it easy for clinicians to do the right thing faster? And the right thing is the question. And so very practically, like today we have AI companies automating dictation, right? Their ability to just take notes really, really fast. And that's just that simple thing alone has made it easier for them to practice. But if we just sort of walk the step from there, going from taking notes to transcribing to if they have to, in real time, think about what is happening with this patient, if this person has 6 encounters and you've got to go click, 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 click to look that up, that is like easily 50 minutes that they don't have. Right. AI could easily go in, surface the right information, make sure no critical information is missed, and surface that up. So simplifying workflow to make it easy to do the right thing, searching for information and making it easy to reduce cognitive burden, and then, of course, diagnostic excellence, right? The ability to look at millions of records to identify, like in our case, we've done a huge amount of work in conditions like pressure ulcers, sepsis, common bread and butter conditions. Yeah. A huge impact from a leading cause of hospital death, sepsis. And opportunity to, again, use AI to identify patients early, just like Victor said, but then also kind of layering how you deliver it in a way that you then make it easy for the clinicians to do the right thing. So I think it'll be transformative, not just in new treatment modalities or new diagnostic modalities, but also the way we deliver care.
Right. And so it sounds like the optimistic vision of the future is one where we can remove some of the administrative tasks and the things that maybe providers don't love and isn't the best use of their time, so that they can actually focus on solutions there. I want to talk about early detection, and I want to talk about that a lot, especially because I think there's a lot of interesting information in early detection when we're talking about quality of care and possibilities for the future. Why don't we start with blood tests? And what's the role that blood tests could play in the future when it comes to early detection? And I think you have some interesting thoughts
Yeah,
here.
sure. No, I'm happy to talk about that. I think it's an incredible opportunity. I began to mention it in the previous question that we've developed an approach that is called Delphi that looks at essentially the way DNA is fragmented in the blood. And the benefit of this approach is it has a vast amount of information. The analogy, it's like a Star Trek tricorder. You can essentially go over somebody with this test, and you can identify, one, if they have cancer, and two, where it's coming from. And you can do it in a way that's easy to do, accessible, and inexpensive. And so this offers the possibility of just saving lives. I think the estimates are, I'll give you an example, in lung cancer, we know early detection of lung cancer and screening saves lives. But in the US, only 5% are getting screened. And so there's an incredible opportunity there. We've developed a test. It's just been clinically validated. It's called First Look Lung. Delphi Diagnostics, a spin-off company, has clinically developed this, and it's now approved for use, and it's being used in health systems. That test, if even modestly utilized, could save thousands of lives per year. Mm-hmm. And so you've got to think then about, there's other cancers, there's the possibility of doing this worldwide. I think the potential is really enormous. And when you think about early detection of cancer, obviously that cure rate is so much higher than when the cancer is detected late. So there are just enormous possibilities of improving the well-being of society, but also just obviously increasing the longevity of individuals and reducing the mortality of this disease. Yeah. So all because of AI, frankly.
Alex, I'm curious to hear your perspective on this. My understanding is earlier this year, your team published a paper that detailed the process for creating the first drug created with AI, which is now in phase 2 clinical trials. Congratulations.
Big news that we can also reveal that just completed phase 2A.
Wonderful. 2 questions about this. First, was it difficult to enroll people in this trial because it's a drug that was created with AI? Did you find that difficult?
It was not at all. Because the beauty of the regulatory system when it comes to drug approvals, you have a very, very regulated process where regardless how you discover the drug, you would move with the speed of traffic. Mm-hmm. So, and usually when you are presenting a potential life-saving therapeutic, especially if you have a lot of published materials and peer-reviewed journals about this specific drug, about your technology, people get the confidence, and the FDA is the ultimate authority, right, which has all the rules and regulations in place to make sure that the drug is safe and effective. That's why when you are enrolling people into studies, usually for a therapeutic, it's very regulated, and they usually don't care how it was discovered.
Interesting. So you didn't confront any skepticism from people who were less familiar, less understanding with AI? It seemed like that wasn't a barrier in this.
No, we have not. As a matter of fact, we were welcomed by the clinic. So now a lot of people started watching this program.
Yeah.
And the beauty of this paper that you've just mentioned in Nature Biotechnology this March, we've detailed the process of discovery going all the way from disease modeling, identification of this disease target, this common criminal in idiopathic pulmonary fibrosis, but hopefully also implicated in aging. We demonstrated we can apply a form of generative AI to design chemistry with the desired properties end to end. And this process that used to take 6-7 years with a traditional approach, we demonstrated that that process took us 18 months.
Oh.
And then additional year to get into human clinical trials. And then you move the speed of traffic. You just another year to do phase 1, and now phase 2. I must say, when the readout came out last week, I cried for almost 2 hours. Oh. And I'm not a crying baby, right? I'm just looking, when you see the drug that is tangibly, clearly has a dose response in patients, and it took you 4.5 years to, ultimate fear, because regardless of how you discover a drug, the longer you wait, the further you go into clinical trials, the stakes are higher. It's a molecular casino, and you're a player, just like with everybody else. And at the end, when you hit a bingo and you actually understand that you're helping patients, I think that I don't have children, but I think that's probably like better than childbirth, right? So it's kind of that feeling. So if you want to get your kids into something cool, you just want to do it again and again and again. Just want to approve.
Yeah. Childbirth, maybe not. People aren't a big fan of children, I can imagine.
Sorry, I don't know about that.
Yeah, totally understandable.
It's a little different, I think.
Suchi, I want to hear a little about your thoughts on AI-based clinical augmentation, and specifically in your work with Bayesian Health. How are you thinking about this technology, and what's the future?
Yeah, I think that's just, we're in this setting right now where there are not enough clinicians, physicians, nurses to take care of the amount of healthcare that needs to be delivered and delivered correctly. We're also in a scenario where there's so much good tools can do to help us go faster and better that we're not doing yet. So 3 very simple examples. The first is, when you look at really high-performing centers or high-performing clinicians, there's an opportunity with AI to learn what makes that possible, right? Whether it's early detection, whether it's targeting drugs, whether it's knowing what treatment to give in a particular context. I mean, medicine is all about decision-making, and decision-making in complex situations where a lot of data is available, and the difference between a really high-quality versus, the difference is basically your ability to leverage that data. So one, how do we learn from millions of records to, in that moment, facilitate high-quality decision-making? So it's democratizing excellence and hardwiring excellence. 2, can we do that in a way that it's not just sitting in a research paper, but it's available at the point of care?
Right.
And can we do, and we know it takes 17 years for, in our published research, we show that it takes 17 years for something to become like, from a trial in RCT showing benefit for it becoming the standard of care. That's bananas.
Yeah.
Like, shouldn't we be able to have like great ideas, and then, obviously it should go through this process where people understand what it means and can deliver it safely, but instantly is then available nationally? Like, why can't we do that?
Yeah.
And with AI, there's an opportunity to cull the literature, to cull the data and evidence that's available, and then make it available at the point of care, relevant to that patient at the time, as opposed to making clinicians learn about the million possible things in books. And, in the moment, it's hard to remember. So I think this notion of like hardwiring clinical excellence, shortening our ability to bring best care to patients, and making it easier for clinicians writ large to do the right thing more easily than what we do today in our system. And that's it's like worse for patients, worse for the caregivers, worse for a system, because there's a lot of waste that comes out of it.
Yeah. When we're talking about AI's use presently today, we, I think, have all been confronted about how it's lacking, and there's at times it hallucinates. There's so many examples of there's so many examples that could make us a little nervous or give us some pause. I think the hope that we're talking about in the future is that we have found ways to reconcile some of those gaps that exist. But I'm curious, and I imagine the three of you have different perspectives on this, but what makes you nervous about the future of AI when it comes to healthcare?
I want to actually start with a little correction. Like, I think there's this common myth people have that AI is one thing. So as a result, they think AI hallucinates. But that's almost a little bit like saying software hallucinates. Because you can build AI very different ways. So think of it as like a whole bunch of fundamental building blocks, and then you're putting it together to train the system to do something. And ChatGPT, which is the common reference point for many people, happened to be trained to be an entertaining storyteller and a poetry guy, right? Like, could come up with like a fun thing I could tell my mother-in-law in a Texas twang. Like, wasn't meant to give me like, grounded advice. So one, there's a lot of ways to like, there's a lot of advances that was underlying ChatGPT, but those advances are being used now to develop things that are grounded, that don't hallucinate, that are validated. I mean, they require deep technical expertise in the field, but I think that's happening, and that's been exciting.
Yeah, I think people think of AI as something that writes emails for you. That is not, that is not what we're talking about in terms of in medicine and in these endeavors that we're discussing. So for example, we're focused on utilizing tools like AI to assess millions of data points that we're measuring in a very specific way. We know to measure those because the biology tells us that cancers are different in a variety of ways. That has to do with their genome, the way their genome is packaged. Those cells, when they die, they make it into the blood, and we measure that, and that's exactly what we're focusing the AI tool on. In that way, and it's very hard for a human to look at millions of data points and figure out the best algorithm to distinguish individuals who have cancer from those who don't have cancer, but AI can come up with classifiers that are actually really useful. But that is the type of, I think, AI application that will really change medicine in a positive way. Of course, it'll help us write emails better for fun, but that is not, and it will, and those are not the sort of concerns we have about that, and privacy and so forth are not the issues, at least with respect to the molecular tests that I see, or the drug discovery tools that you're discussing, or even I think the sort of enhancement tools that you've been mentioning. So anyway, I don't think it's that much.
I have two fears.
Yeah, tell me.
So one fear is that, my first paper in generative AI for small molecule chemistry was 2016, and then a bunch of papers 2017. And when we were publishing those papers, we were thinking about, how to ensure that, bad actors don't get access to this technology for all kinds of reasons. And we only sell software to the pharmaceutical industry, for example, right? These guys are very regulated. But now, with the advent of ChatGPT and other generative tools, it became mainstream. So pretty much everybody got software that can write software that understands chemistry, medicine, biology. And there are a lot of bad actors out there, right, that I don't know of, but I know that they exist. And that technology could be used in a very dangerous way. So, and I hope that it doesn't happen, but the probability that now we're going to have engineered threats, not only biological or chemical threats in general, I think that the level of intelligence that a lot of those bad actors got is very dramatic. So now they basically are at PhD level, and will get to professor level. That's my one fear. And the second fear is that we actually will see slowdown in AI progress because of a regulation or some malicious event. And in that case, all this huge bounty that we have in the next, let's say, 15 years, I mean, all of you in the audience will have a phenomenal life in 15 years. Humanoid robots will take care of your home and of you. We will hopefully slow down aging. You've seen probably the Eli Lilly presentation today. They're talking about prevention of Alzheimer's with drugs that they're having clinical trials in phase 3. Beautiful company, by the way, please follow it. You can now lose weight without making an effort, just inject, right? Beautiful life. AI, now my company managed to get 9 drugs into clinical stage, basically ready for humans or in humans, 2 phase 2 human clinical trials, and I'm an AI person. I never expected it to happen with the help of AI, right? Usually, we nominated 9 preclinical candidates in 2022. Big pharma usually nominates, 4 to 5 in small molecule space at that quality for novel targets. So that's a miracle. And right now, there is a certain inertia before we see the propagation of those technologies into mainstream. So even for our AI-discovered drug, phase 2 just read out, phase 2A, preliminary data, all the disclaimers, but it's, I cried. But that took 4.5 years, right? So what we are discovering right now is going to, in the next 4.5 years, we might actually target the fundamental processes of aging. And that's the process that all of you have, right? And all of us are going to die at some point in time. But you want to die later and healthier and as late as possible and see more life. If we do see a slowdown in AI and technological progress, either for regulatory purposes or some malicious event or both, we are not going to get there. So right now, we need to ensure that we work together to accelerate AI progress, but also in the most responsible way, in the most responsible places.
You made a good point earlier about the data sets that these tools rely on, which can sometimes exclude certain communities or certain types of people, which can obviously create big gaps in what our understanding is. But I want to move on to a question to you, Victor, to get very specific. It's your belief that most traditional liquid biopsies are just not very efficient when it comes to an approach to cancer detection. Can you say a little bit more about that and what you believe is the more sophisticated way of targeted cancer detection?
No, thank you. I think the issues have been, and first of all, there's been a lot of education about early detection. I think it's great, and a lot of companies have come out and started to do that. I think the key with early detection is a couple of factors. One is you have to detect early stage disease, and you have to do it with really high sensitivity. It's in early stage disease where if you intervene, you can actually make a difference and cure patients. And then the second thing is these tests and the approaches for detecting early stage disease and cancer in general have to be inexpensive. They have to be accessible. Just to the point you were making, they have to reach all members of society regardless of socioeconomic or geographic and so forth disparities. And they can actually be a way to decrease health disparities if you do it in the right way. So we've developed what we believe is a next generation liquid biopsy approach, which basically looks in the blood with high sensitivity for early stage disease and in a way that is inexpensive and easy to do, and that we think could be widely accessible in the US, but frankly around the world. And we were talking about this just before this session. There are a number of countries around the world that are desperate for early cancer detection. And rather than have them try all the failed methods that we've gone through that are expensive and inefficient, they could actually leapfrog all of that using an inexpensive approach. And so we've actually had interest not only in the US, there's healthcare systems that are using these tests already, but even countries around the world where they would love to benefit from this kind of thing. So I think there's honestly exciting opportunities ahead in that space.
That's great. And we will turn to the audience very soon for questions. But Suchi, a question for you. You spent a lot of time thinking about and working with what guidelines should exist so that AI's role in healthcare is done responsibly. Can you say a little bit more about what you consider and what should organizations consider when they're thinking about the pairing of AI and healthcare?
Yeah, I think this also speaks to your risk question, right? Where we worried. Interestingly, what we started seeing in 2018, 19, 20 was that as now more electronic health record data are available and many of these technologies are available, people start downloading and implementing systems, but they're not coming at it with the same level of rigor that we need in medicine. So they don't have any studies supporting it. There is nothing that shows like, you've thought about the risks. Have you thought about confounding? Have you thought about populations? And so as a result, like people were releasing tools, in fact, even within electronic health records, people were releasing tools easily. Either they were just building it in-house at a system and releasing it, or from tech companies or vendors just releasing it. And there are a number of stories, like there's a story in like Michigan where there was a tool on sepsis detection that Epic, which is the electronic health record builder, had released. And it turns out it started firing all over the place and had the risk of both missing key patients, but also overtreating and causing enormous provider fatigue. And so there was sort of like multiple issues. And so then they had to shut it down. When people went and started thinking, like analyzing, well, how does it work? Naturally, people started realizing, oh, there are so many things you have to think about in measuring efficacy, almost like a trial, right? That today's systems don't think about it, they don't have the money to do it. So we came together, so in my research, both with the FDA, but also through an organization called the Coalition of Health AI, we brought together individuals from life sciences, health systems, payers, also various federal groups and some medical societies to come together and start coming up with best practices, because these best practices do exist in the research community, but the problem is they're not like understood widely. So how do we take that and like sort of more broadly disseminate, understand, align, and then partner to make it easy to validate? I think independently at a place like Bayesian, part of the reason for founding Bayesian was that instead of doing marketing-based care delivery, which in AI has been, AI hype is a very real thing.
Yeah.
And this is like probably the third wave in the last decade. The last big one was in 2016, 17, when deep learning was all the rage, and people thought it was going to solve world hunger. Yeah. So I think part of that is, separating like the good, the wheat from the chaff, right? Like how do you tell apart places where, and for Bayesian, as we've built and implemented, like, so in 22, we published these massive trials. They were first of a kind, the first to show AI implemented at the point of care, nearly 20% reductions in mortality from, in a pragmatic trial, 5 sites, 4,400 clinicians, 750,000 patients. So it was a lot of work to do.
Yeah.
And just non-standard, because people don't know how to fund things like this. But I think very necessary.
Yeah. Great. We'll turn to the audience for questions. We should have some mic runners here, and if you could just introduce yourself before your question. I think right there.
Thank you. I'm Robert Overell. I'm a retired biotech guy. So it's a question for Alex, and for those of us that are hanging on by our fingernails trying to understand what AI is, I wonder if you could take it to the next level for us. In other words, is the AI that you're using helping you look at the Lego blocks that build these chemical molecules and how you put them together? Or is it looking at the interaction of the molecule with the target? Or is it looking at some kind of a toxicology database to help you with atomic properties of the drug? Without getting too technical, can you help us understand that?
Sure. So what we do, and I think that most people kind of are starting to adopt those approaches. So we have a model zoo. So it's a zoo of different AIs. That's how they usually refer to it, or you can call it as AI orchestra. So you've got domain-specific tools that understand fundamental biology, for example, and now we're building tools that understand fundamental biology in time. Like, for example, some of the data types that Victor is, the ultimate virtuoso of. Some of those data types can be also comprehended by AI, maybe not at those levels as very domain-specific purpose-built models. And we have chemistry. So those AIs are usually trained, and we like to use public data. So I don't use personal data. By the way, there is about $2 trillion of data available that was produced by US government alone. Thank you, right? So they managed to fund all the world's research using the NIH, right? NIH spends, what, $45 billion or more a year on research. That bears fruit in the form of data, and it's openly accessible for the world. My God, right? So you use crawlers that go and hunt for this publicly available data, mostly biology. So it's gene expression, protein expression, those data types that change in time and define who you are in multiple animals. And we train biology AI on that data to identify mechanism of disease and also identify those common criminals that are causing this disease, those protein targets. And we also try to understand aging. So like think of yourself as a video from cradle to the grave, right? Regardless of what you do, you're going to decline and die, develop diseases in the process, sorry. Nature is unfair, right?
Matter of fact.
So generative AI is very good at capturing those trends, right, in time, and then you look at for targets that are implicated in aging and disease at the same time. That's my approach, and we have a form of AI for that. And then we present those protein targets to another form of AI that is trained on entire totality of whole chemistry knowledge. As a matter of fact, my chemistry AI that is used for drugs is now also used for CO2 capture, for new materials, for metal-organic frameworks and other things, right? We also use it for agriculture. So now those models understand how not to hurt bees, etc., right, with all kinds of pollutants, and even oil chemistry. So there you can now create more generalist agents. And then you have reasoning systems in the form of similar form of intelligence like ChatGPT that you can branch out in the form of agents. Those are kind of robots that you create out of systems like ChatGPT that ran those domain-specific models. And then you basically ask this entire system, this Lego that you've created with this reasoning system, to go from to find the shortest path from the disease to clinical approval. You create this hypothesis, and then the hard work begins, which is you need to test it on animals, you need to many animals, you need to test it on humans, and that's your 4.5 years. Usually what I've just described in AI happens like in a couple weeks, and then you go and validate.
I think we have time for one more question. Yes, right there.
Hi. So I have a question about, can anyone comment on the landscape of policies in AI in healthcare, specifically with sharing of data? And so, for example, if one company finds early detection for cancer, but then now you own it, how does that work? What do you think the policies will look like around the world? I guess where are those limits set where there's some information that you have to share and make accessible to everyone else?
Yeah, I can take a first stab at this. That's a great question. I think one of the things that we've tried to do historically has been to constantly publish the kind of work that we do and the research that we do. And so starting with this initial method that we described, looking at genome-wide cell-free DNA fragmentation for early detection, described in Nature in 2019, probably about 10 more papers that have occurred since then describing this. And these days, whenever a paper is published, all the analyses that you do, both the original data, sequence data that you obtain, the intermediate analyses, the algorithms that you use to make that are ultimately published as well. So a lot of information is public. There is IP, and there are ways in which companies can protect some of the work that they do, which is rightfully important because they ultimately they spend a lot of money, let's say, developing this, even after the initial, let's say, academic discoveries occur. And so that, together with know-how, end up being what is sort of proprietary and useful for the company when they develop, whether it's a diagnostic test, a screening test, or a drug. But certainly the information as to others, for others to be able to work with this and to validate it and to try new things is certainly there. And I share with you the concern that, we don't want to be closing this kind of information. We want to make it available to folks. We also want to balance it so that there's an incentive to new entities to actually develop a diagnostic test, to develop drugs and so forth, and to be able to use that to help people ultimately. Hope that helps.
Thank you. That's all the time we have for today, unfortunately, because I know we could keep chatting, but thank you all for joining us.
For a conversation produced by our underwriter, Evernorth Health Services, here to discuss how AI concierges tackle the toughest customer yet, the U.S. healthcare system. Please welcome Katja Andreessen, Chief Digital and Analytics Officer at the Cigna Group. Here to lead the conversation is Megha Garibaldi, Chief Growth Officer at The Atlantic.
Hello. I hope everyone's having a great afternoon. Thank you to Katja Andreessen, who joins us today, the Chief Digital and Analytics Officer for the Cigna Group. And we're going to talk about AI and healthcare, two very simple things put together. So let me get right in. Katja, why is healthcare so complex?
Healthcare is complex, for sure. Does anyone here disagree with that? Okay. It's because it's fragmented, it is very complicated, and it is very hard to understand what is happening, how to navigate, et cetera. And I think it's really important to understand that problem statement, because I will tell you, when we think about AI and technology and what to do about it, a lot of times people treat that symptom instead of the real problems with healthcare, and so we focus on solutions that help you navigate a Byzantine system, or we focus on solutions that help aggregate all the choices you might have, right? And those are things that actually make it worse, not better. And but I'm very excited about this moment with AI, because I think we actually have a once-in-a-lifetime opportunity to make that better.
Well, can you give us a quick definition of AI as you see it? Because then we can talk about AI within the realm of healthcare and what this means for all of us.
Yes, absolutely. So this is my non-technical definition of AI. But when we talk about AI, that's an umbrella term. It means any time we're using computers to mimic human cognition. There's something called machine learning, which is a subset of AI, which we've been using for a very long time at Cigna and at many companies. And that's just teaching a computer to teach itself. And then there's something called deep learning, which you may have heard about, that opened the door to a lot of generative AI, which is just everything I just described, only with huge data sets and way more complexity and way better predictions. And then we come to generative AI. And I don't want to conflate the two. Generative AI is when the computer is generating content, like unique content. And that's different. It's a subset of machine learning and deep learning, but it's different. And there's tremendous value in that whole spectrum of things I just described. And not everything's appropriate for generative AI. And sometimes generative AI is a better solution than machine learning or deep learning.
Absolutely. Okay, so let's bring it down to us, right? How can AI in healthcare benefit, say, me, the consumer, the customer? What does this look like? How can it make my life less complex, easier, and truly benefit me?
Yeah, that's one of the things I'm most excited about, is I think this is a unique opportunity to have healthcare make sense. And the way to make healthcare make sense, I think, is very important for it to be as personalized as possible, to be as predictive as possible, and then to follow you along your journey. So that's what we're very focused on, is how do we get out in front of what might happen to you? How do we engage you with just what you need to know, not everything under the sun, not helping you navigate the entire healthcare system? So an example of how we're doing that I'm excited about is, it's simple but revolutionary compared to the status quo, which is creating just chat interfaces, like if any of you played with ChatGPT, but for your healthcare. So explain my benefits to me, right? That's something that we're launching. Or uploading a picture of an explanation of benefits, that really fun document you sometimes get in the mail. What does this mean? Why do I have this deductible? What do I need to do next? So taking that, taking out the jargon, making it explainable, and making it really human-centered, which is where I think our healthcare system has often failed us, is it's sort of like a big, complex system that we rely on people to navigate instead of wrapping the system around the individual.
Right. I usually feel like I need to learn a new language to understand what my benefits are, so that is good to hear. What about the other side? What about the healthcare providers and all the sort of middle services in between?
Yeah.
How does that end up looking like?
You know, it's interesting. I just was reading this week about a McKinsey study that said that 1/3 of healthcare providers are planning to walk out the door in the next 5 years. They're burned out, unhappy, tired. Okay, so why? So one is compensation is a big issue, but the number 2 and number 3 reasons were around, it is so hard to do all the paperwork, I need more support staff, negotiating all this complexity. This is just burning me out. And so I wanted to give an example of how we're trying to combat that with AI. So at Cigna, we have a solution called MDLIVE, which is basically virtual telemedicine. You can call to a doctor, do video with a doctor anytime. And in the past, after that encounter is through, the physician has to sit there and write up notes about what happened. And in that world, what happens is it's about 90% of the time is spent on administration and 10% on the patient. And if you've been to the doctor's office, not on video, but in real life, you've seen that, right? They're walking in with their computer, they're taking notes, they have all kinds of things they have to do afterward in terms of administration. So what AI can do is listen to the encounter and dynamically create a summary that is very high quality. Now, I will say AI is the most promising thing I've ever seen in terms of technology in my lifetime, but also the scariest. So you wouldn't want the summary not to be read by a physician. But a physician can read the summary, and then the AI can also suggest things that maybe the physician could have done better or different next time, or things to follow up on. So it's doing all that work on the administrative side, and it reduced the time on administration by 90%. And what does that do? It opens up the ability for the physician to spend more time with the individual.
That's great. So based on what you're saying, it feels like it makes our lives easier, both on the consumer side, the patient side, as well as the doctors and the administrators. Now, how does this revolution and the advancements also make us healthier? Because talking about the health in healthcare, not just addressing sickness, but improving health as a whole, what do you think the benefits are?
So there are two things I'm excited about. One is sort of outside of Cigna's realm in health sciences, which is new drug development, the ability to diagnose things much earlier. I've spent time at Stanford Medical School, and the things that are being done in radiology with mammograms, et cetera, to predict diseases ahead of time based on these massive data sets is very exciting. So I think we're going to see a tremendous amount of innovation unleashed in what treatments are available to us. At Cigna, we're very focused on, okay, how do we predict, though, who might need those treatments, right? And then how do we motivate people to take steps based on that information that are going to make them healthier? Right. That is the hardest thing in healthcare. Yes. It's not necessarily a lack of data and information, although it's very fragmented. But it's actually, okay, but what are we going to do with that information? And then how do I motivate you or anyone else to take the steps they need to be more healthy? But the really interesting thing is you can apply AI to both of those things. Mm-hmm. So what we're doing is building increasingly predictive models that allow us to determine who is likely to have what conditions, right? And then that allows us to get out in front and begin to engage with people in actions that might change their trajectory for the better. And then on the other side, send them engagement messages, use digital channels, use nurse care advocates on the phones to persuade people to take those actions, which is the tricky part. But you can use AI to run very complex models on what's most likely to motivate who, through what channels, at what time of day, right? And that's the real holy grail of healthcare, is changing those behaviors. And my favorite example of this is my team has been working on models that predict what children might have developmental delays, or developmental delays that are an early signal for autism. So what they found was we have predictive models that can say, it looks like there might be a delay. We should engage with the family with resources, right? And not necessarily saying, hey, it looks like your child's developmentally delayed, but saying, hey, would you like to talk to a nurse advocate? Do you have kids who are struggling? So that's one program we have that gets out in front. But then the really interesting part was testing what motivates the family members to then avail themselves of those resources. And so we tested all kinds of different behavioral science-based messages. And what was really interesting was the one that was the least intimidating and most supportive was when we said, hey, if a child is struggling, that can be hard for the whole family. Would you like to talk to one of our nurse advocates about how to navigate all of this for your family, right? And so it's so interesting to unlock the science of the human brain and what motivates us. At the same time, we're innovating in health sciences.
Right. I mean, as a mother of 2 young children, that sounds excellent. Well, thank you so much for joining us, Katya, and thank you to all of you.
Thank you for having me.
And now for a conversation on AI regulations to empower patients and physicians. Please welcome Micky Tripathi, National Coordinator for Health Information Technology and Acting Chief AI Officer at the U.S. Department of Health and Human Services. Rebecca Mishuris, Chief Medical Information Officer and Vice President of Digital at Mass General Brigham. Amirah Sequeira, National Government Relations Director at National Nurses United. With AtlanticLIVE contributor, Kathleen Koch.
Good afternoon, everyone. Thank you for joining us. Well, I know that you have been hearing over the last hour or so about just some of the amazing ways that AI is changing or will change medicine. But at the same time, it has such great potential, right? But here in the United States, we have no comprehensive, overarching federal laws or regulations that govern the use of AI in medicine. Now, Europe, they do have the Artificial Intelligence Act, and that went into effect in February. But Micky, I'd like to go to you right off the bat with this. I know that might sound scary to people. We have no overarching federal law to regulate this, but that doesn't mean the federal government's not doing something. Talk to us about what your office is doing in conjunction with the FDA to regulate what AI is currently being used in medical care.
Sure, happy to. So it is true, we don't have an overarching AI regulation about the use of AI in healthcare. In part, we have a different society than Europe, and so we've got a different form of government. You've got federal government and states, very distributed authorities, very fragmented healthcare systems. So we've got to think about it in a different way. So I'm in the Department of Health and Human Services. We oversee the department, which has a number of agencies that are probably familiar to you: National Institutes for Health, FDA, CDC, CMS, HRSA. And what we've been doing is looking broadly across all of our operating divisions and saying, what is sort of the overarching strategy that we want to be able to have? And we have different regulatory sort of levers that address different parts of the healthcare delivery system. So right now what we have, and we're doing a lot of thinking now with the strategic planning process that we'll have a strategic plan in January, so there'll be more to come. But right now, there are a couple of different things that are already in place. One is the FDA has been regulating medical devices for decades. And one category of medical device is called software as a medical device, which are really AI-enabled technologies. And they've approved now almost 1,000 software as a medical device solutions that are available on the market. And so those are devices that have to go through a pretty rigorous process to evaluate the safety and the effectiveness in order for them to be approved for the use in the US. If they don't go through that process, they're not allowed to be used in the US. So that's already in place and it's ongoing. As I said, over 1,000 or almost 1,000 devices have already been approved. In the Biden administration, we've had a set of regulations from my office that's related to the use of AI technology in electronic health record systems. So 97% of hospitals and over 80% of physician offices use certified electronic health records that are certified by my office. We have requirements that go into place starting in January 2025, and we'll hear about how those are how that's going to work in a second. That requires that there be transparency about the AI technologies that are in that electronic health record product, because the concern that we had was that physicians would be getting sort of a black box, and they would have no idea what AI tools were in that, and then they were trying to make medical decisions, not really fully understanding what is driving the results of what they're seeing from their product. So we focus first on saying, let's get transparency so that the clinical users of the world will know what's in there, and then they can do what they do every single day, which is they make decisions about what are the best medications, the best procedures, the best therapies for their patients. Surely for AI-enabled technologies, they ought to be able to do the same thing, which is to say, is this tool appropriate to my particular circumstance, to this particular patient, to my patient population? And if they decide no, then they don't have to use it, but at least now they're fully aware of it. On the other side, last thing is Medicare has already started putting into place certain types of regulations related to the uses. So they have issued a couple of guidances related to the uses of AI in certain health insurance products like Medicare Advantage that would require that a person be in the decision-making process as it relates to medical necessity checks, for example, or coverage determinations. So you don't have an algorithm that's just taking data and automatically deciding, oh, that person is not going to get that kind of care, denied, without a human actually stepping in and saying, wait a minute, is that actually accurate?
Because aren't there concerns already that some of those decisions have been biased?
Those are already,
Right.
yes, yeah. There's been a lot of evidence that that there's been errors. There've been all sorts of things related to inherent bias in these systems, and so we just want to make sure that a human, at the end of the day, is interpreting that and making sure that in that particular situation it actually makes sense. And then last thing I'll point to, since you mentioned bias, and I almost forgot, is the Office for Civil Rights issued a regulation related to what's called Section 1557, but it's about non-discrimination, which has been in place for a number of years in the Affordable Care Act, but it was more a reminder to everyone covered by that, which is health insurers, providers, and others, that you're not allowed to exhibit or to act in a discriminatory manner as it relates to healthcare. And the reminder was that AI, just because it's AI doesn't mean that you're absolved from that you still are responsible for whatever actions you take. And if they're discriminatory, you are still responsible for what happens with that.
Rebecca, your hospital, Mass General Brigham, is one of the many that's launched its own AI governance committee. That was last year. Now, tell me why you decided to go that route. How is it working out? And you're a doctor, so you're experiencing the ramifications of this yourself every day, correct?
Yeah, absolutely. So I am a primary care doctor, and so I use these systems regularly in the care of my patients. I'm also the CMIO for our system, and so I am in charge of how we use technology to actually deliver care and to improve the care that we're delivering. And over a year ago, we launched our AI governance committee, and the first job of that committee was to develop a responsible use of AI guidelines for our organization because we had nothing else to look to, right? The federal regulations didn't exist yet. There are some societies out there that are putting out similar things, but we thought it was really important as we were pursuing these new technologies that we had a set of rules that we were all going to play by within our organization. So things like addressing bias and making sure that the system itself was equitable in its output. Things like transparency and demanding of the vendors of these products that we understand, to the extent that anyone could, how they were working and how they were providing us with recommendations. Accountability, I can kind of go on, there's a list of about 9 of them that we came up with. One of the most important ones actually was benefit, right? Really wanting to make sure that these technologies were benefiting our providers and our patients. The same way that we would with any other technology that we would put into clinical care. If it's not providing a benefit to our patients or our providers or somehow else in the healthcare ecosystem, why are we using it, right? And that, in that regard, it's really no different from any other technology that we might put into place. The committee has been wildly successful. What we did was actually put together a group of leaders across our organization, so not just from the technology space, but from our chief quality officer, legal, health information management. Our ethics committee is represented on the committee as well, and a number of others. Again, to bring all of the aspects of healthcare together so that we could best evaluate this relatively new technology. And when I say new, I mean generative AI, right? Analytic AI has been around for a long time.
And a lot of hospitals are doing this, right?
Many hospitals are. And I think in the absence of other guidance, right, people are coming up with their own. I think somewhat reassuringly, we are all landing in similar spots around things like bias and transparency and accountability. But it would be really nice to be able to have some universal guidelines in place that we can all share, and also that the vendors themselves can comply with. Right? Those vendors are not out there to sell to a single hospital system. They're out there to try and benefit healthcare across the country or even across the world. And if it's different at my organization from another, or different in Massachusetts where I am from another state, that makes it really hard to develop these tools in any sort of robust way.
So Amirah, we heard what the federal government is beginning to do, what hospitals are doing, states are passing laws as well. You represent nurses, so nurses are on the front line of healthcare in dealing with AI in some cases every day, really. What do you think? What are your concerns about these guardrails, be what they may, as they exist currently?
Thanks, Kathleen. So first, before I start, I do just want to say on behalf of the 225,000 unionized registered nurses that NNU represents, we stand in solidarity with the Atlantic Workers Union and support them in their pursuance of a strong contract. So we stand in solidarity with our union brothers and sisters here. Thank you for this question. So what we are seeing on the ground, what our nurses are seeing in the field in hospitals across the country is that AI, different forms of AI, have been rolled out now for a few years, virtually in the wild, without pre-market testing, without approval, and without the nurses' understanding of how it works in the systems they use. When I speak about AI from a nursing perspective, I'm talking about the ways that AI is now impacting nursing practice, which is related to but different from medical practice and medical diagnosis. So we are seeing forms of AI rolled out in EHR systems already, making determinations about a patient's acuity, about the need for certain staffing levels that do not match up to the registered nurse's professional judgment of what a patient needs in terms of their acuity, in terms of their staffing levels.
And what happens then?
So what happens is then the AI system is determining what the staffing level should be in a unit. And we have nurses across this country who are experiencing their hospitals reducing staffing levels in their unit at a time when we are already thoroughly understaffed across this country, when nurses are leaving the profession because of high rates of moral injury because the understaffing is so severe. Hospital employers are actually further reducing staffing levels in units because of what AI systems are saying.
Now, what we're hearing, though, so much about AI, excuse me for interrupting, is that it's going to take away those administrative tasks that sap your time away from being with your patients. It's supposed to help you.
So I think when it comes to nursing practice, and again, I'm speaking specifically about nursing practice, patient interaction, one-on-one patient care is fundamental to nursing practice. When a nurse is performing their nursing assessment, every interaction with the patient is a part of them assessing that patient's acuity and what that patient needs in their nursing care plan. The more that we take away that one-on-one interaction with the patient and replace it with technology, the more difficult it is to ensure that that patient gets the quality nursing care, the safe, effective, therapeutic nursing care that they need.
Micky, what is the federal government doing to address concerns like those of the nurses? I know that in the president's, the executive order on AI that came out in October, it required HHS to create a safety program to receive reports of unsafe AI healthcare practices and take action to remedy them.
Yeah, so as a part of that process, we're looking at a couple of things. One is how do we think about the patient safety organization network that exists today and have that be enabled to also be able to detect and report on AI safety related events. That's a lot of hard work because that's a voluntary network and there aren't real good data standards around any of this. And so, we're thinking really hard about how we would do that. That could be coupled with the technology capabilities that we're requiring in regulation in electronic health record products, because a part of what I was describing before that's a requirement in these electronic health record systems is the ability to essentially report within the electronic health record system if you detect as a clinical user, whether it's a doctor or a nurse, an issue with the AI-related tool, so that it actually is stored. And then that begs the question of what happens to that stored data. If it just sits in the basement, then, so then we'll have to think about, well, do we need to do more to get people to act on it? Or does that start to kick in the regular patient safety processes and other kind of processes that can help to do that? The other thing that we're doing a lot of work on is thinking about how do we in general have some type of approach for assessing the quality and safety of these AI-enabled technologies as they're used in the market. We don't, as you were pointing out, there are some types of technologies that don't fit into the category of a medical device. So they're not going to go through that FDA process like some of the technologies you were describing, yet they're being used. And we want to make sure that those have high quality and safety, and protections against health equity issues and all sorts of other issues. So a lot of work being done on the private sector and the public sector to think about what's a framework for thinking about how you would assess the quality performance of a particular algorithm, developing more industry conventions around that. And does that mean a public-private network where, let's say, and I'm just sort of thinking out loud here about how we're thinking about possibilities, you have an AI-enabled technology that you want to use in a clinical setting. Would Mass General Brigham at some point say, we're not going to use that unless it's gone through that safety lab, like the underwriter's lab, like we think about for electricity, or certification through the ONC program that I manage. There are different ways of thinking about that, but we're first saying, how do we develop the metrics and the areas that are quality issues and how we would measure those things, and then how would we develop an infrastructure, both a policy and a technical infrastructure, to actually do that kind of assurance testing.
Rebecca, you wrote an op-ed expressing your concern that AI could widen existing disparities in care. How is Mass General Brigham working to assess these new AI tools that are now at your fingertips to make sure they don't do that, to assess them with that equity lens?
Yeah, so equity is really at the core of everything that we do, and that quality and safety and equity of the patient care we deliver has to be our North Star. And so as we evaluate these technologies, we are looking for potential both improvements and also widening of existing disparities. We want to obviously see the former, not the latter. But we're doing things where we're actually testing them out and looking at the outcomes and saying, actually, are we seeing equitable outcomes? And equitable, right, is not equal, right? It sometimes you have to move the needle more for one group of people than another in order to get everybody to the same playing field. So for instance, as we implemented ambient documentation where the AI is actually listening to our clinical visit and then drafts my note for me, we looked really hard to make sure that that was actually going to be able to be used across all of our providers and all of our patients, no matter what language they spoke, what kind of accent they had. And so we actually did empiric testing in that and found that actually the ones we're using do really well if you've got a heavy accent or if you're speaking another language and there's an interpreter in the room, and even going so far as to be able to work if the provider and the patient are speaking the same language, but it's not English. And so there, I think we're actually moving the needle forward for equity and actually narrowing that gap. But you could see how if a system wasn't able to do that, it actually might widen the gap, because these technologies, this technology in particular, is actually putting me back in the room with my patient, where I'm able to spend actually more time with them because I'm not clacking away at the keyboard as we're having our visit. And so if I wasn't able to use that with all of my patients, I would create a disparity where there shouldn't be one.
Amirah, you expressed some pretty deep concerns earlier. I know your union has recently come out with a nurses and patients AI Bill of Rights. Talk to us about that. What does that cover?
Yeah. So just to be clear, when we talk to our union registered nurses across the country, they are really concerned. The issue of AI is a top concern for them, and they are very upset and frustrated with how AI is already being rolled out in their hospitals. So we work to develop a nurse and patient's Bill of Rights to really look at the deployment of AI through the lens of a rights-based framework. And we lead that rights-based framework with noting the fundamental right that every patient should have to person-to-person care, to care provided by a licensed healthcare provider.
So that's one of the rights?
That's one of the rights. That's what we lead with. The right to safety. We believe that we should be deploying the public health principle called the precautionary principle before any form of AI is deployed in any healthcare setting. And what that means is that there should be scientific consensus that any form of AI not only is helpful, but that it does no harm before it is introduced. And unfortunately—
Like the Hippocratic Oath, right?
Exactly. And unfortunately, we already have these AI systems that are being rolled out in our hospitals for which we have no information. There is no scientific consensus yet that they do no harm. Again, I am speaking about the nursing practice-related interventions. The right to privacy, both privacy for data collected about patients and about workers. And what does that mean? The fact that we don't know what is happening with this data in a post-Dobbs, post-Roe v. Wade America, where certainly not just for patients, but for our nurses, there is concern about legal action, about persecution. The right to transparency, my fellow panelists have already talked about the importance of transparency. We're really concerned about that. For nurses, the right to exercise their professional judgment. And I touched on that earlier, that when the hospital employer is saying that the AI system's decision-making cannot be overruled by the trained and licensed and educated registered nurse, that means that a nurse cannot exercise their professional judgment. And actually, Kathleen, we did a survey earlier this year where what we found was that more than half of our nurses, survey respondents, said that they were seeing AI rolled out in algorithmic systems within electronic health record systems, and 69% of those nurses said that the decisions on the nursing care plan that were being rolled out by those algorithmic management systems did not match their professional nursing care assessment for the patients. And this is the crux of why our nurses across the country, to say they're frustrated is an understatement. They are angry about what is happening.
So you're trying to get this Bill of Rights accepted by hospitals, by insurance companies? Who are you
Well,
directing
first, fundamentally, it's very important for us that this is useful for the administration, for the federal government. We are working closely with the White House, with the Biden administration, with HHS, as the administration works on developing AI regulation. Because what has happened here is that AI in healthcare, certainly around nursing practice, has been rolled out by hospital employers without any regulation, and now we're trying to play catch up, right? So we're hopeful that this Bill of Rights will be useful in developing these systems, but also fundamental to the Bill of Rights is the right to collective advocacy and workplace democracy for healthcare workers, that we should have a say at the bargaining table about whether or not in the first place any form of new technology is rolled out in our hospitals that we will have to use. And so that, of course, is something that we are bringing to the bargaining table in union negotiations across the country.
Yeah. Micky, the president, in his AI executive order in the fall, mandated that the federal government come up with an overarching strategic plan on the responsible use of AI in medicine, and that's, I understand, due out in January. You are one of the co-chairs of the task force creating it. Can you give us a preview, a sneak peek of what you're considering?
No,
please,
sorry.
Please.
So first off, let me just say that we also believe very strongly that workforce empowerment is a huge part of what we need to be, very, very deliberate about here. And we don't want AI. So we do believe that AI-enabled technologies on net will be a huge benefit to all of us in American society. We also believe, however, that technologies can be done to people and not empowering them, and workforce being one of those very important ones. In healthcare at large, we don't have enough people. We have shortages of people. And to your point, what we don't want is the technologies to be displacing people when we actually don't have enough people yet. What we want is for the technologies to allow the people who are there to be able to work, as we say, at the top of their license, so that they can actually get rid of more of the rote stuff and do what the nursing profession wants to be able to do at the top of their license, for example, which is that human interaction, which hopefully an AI will never replace. So that's sort of one of the core things that that we certainly believe. In terms of the plan itself, we are looking at 5. The Department of Health and Human Services is startlingly large. I work in the department and I'm just shocked by it every day. But we're looking at research and discovery of medical products. That's the NIH and drug discovery. Everything involved in that. FDA and the regulation of medical products, which is devices, biologics, and drugs, and what are the AI sort of policies that we should have and strategies we should have there. Healthcare delivery, human services. We are the Department of Health and Human Services. We need to pay a lot more attention to human services than we have in the past. And then finally, public health. Looking at all of those, and the cross-cutting pieces that we're looking across all of those is safety, ethical and responsible use, and critical infrastructure and our own internal operations. And certainly the sort of the workforce empowerment and the respect for patient privacy is all a part of the ethical use as well. So those are all the different domains that we're working very hard on and trying to put together. And in January, we'll be releasing that plan.
Rebecca, we've heard today, and we hear it continuously when we have this discussion about the need to not stifle innovation. Yes, protect patients, protect providers, protect nurses, but let the innovation go forward from the point of view of a large health system. What is the best way to do that?
So it's a great question. The best way to do that is actually to allow that innovation to happen within some guardrails, right? And so we're seeing healthcare organizations put up those guardrails themselves. We're seeing the federal government start to do that when, we're all looking forward to January. And within those guardrails, right, we should be able to allow and even foster the innovation with some of these principles at hand, right? With the principle of safety, with the principle of do no harm, and actually involve both the practitioners of healthcare and also the patients in developing those systems, so that we're developing systems that will actually move us forward in healthcare delivery and in some way actually augment, right? I talk a lot about augmented intelligence instead of artificial intelligence, where it's actually helping us be better doctors, it's helping us be better nurses, and we want those technologies to innovate and to come into existence within those guardrails of responsible use.
Amirah, do nurses have any concerns that your Bill of Rights could in any way stifle the creation of innovative AI that could help save lives in the future?
No, nurses, we are not against technology. What is important to us is that we are always safeguarding safe, therapeutic, effective, equitable patient care. And one thing that really concerns us is that there are specific key interventions that we know would massively improve patient care at the acute care hospital bedside across this country that our hospital employers refuse to take. Micky, I'm going to disagree with you, my friend, for a second. You talked about shortages of healthcare workers. There's a narrative across the country that we don't have enough nurses. And that narrative is wrong. We have more than 1.4 million actively licensed registered nurses who are keeping up their licenses, who are choosing not to work in the acute care hospital environment because the working conditions are so terrible. And we know from all of our survey work, and we know from the experience of California that did it in 2004, that if we implemented mandatory minimum nurse staffing ratios, scores of those nurses would come back to work, because the number one reason that drives poor working conditions and, by the way, poor patient outcomes in acute care hospitals are low nurse staffing levels. And so to us, we look at this and we say, the number one thing to improve nursing care and therefore improve quality patient care in this country is to mandate safe nurse-to-patient ratios, which are scientifically proven to improve patient care. So let's take a minute. Let's not assume that AI is inevitable. What we're seeing, Kathleen, is a number of our employers talk about the deployment of AI nursing care. At times, truly, they are talking about replacing registered nurses with AI assistants. Instead of that, they're making that argument by saying, well, we have a nursing shortage. We know that for many hospital employers across this country, the number one way that they can reduce their costs and increase their profits is by reducing labor costs. And so it is really, really important that we are pointing out the various interventions that we already know would drastically improve both the nursing workforce and patient care before we start talking about technology that would replace us.
In the final minutes we have, I'd like to, a minute, less than 2 minutes, just briefly hear your concerns as we wrap up talking about regulation. We've heard about federal regulation, what some hospitals are doing, and we know states are also doing their own thing, California, Utah, Colorado, and others. How do we avoid ending up with a patchwork of laws that are confusing and, and basically really difficult, if not impossible, to enforce?
You mean like unlike most other laws.
Let's strive to do better, right?
No, I mean, we live in a country that has federal authorities and state authorities. There are a whole bunch of authorities in the 10th Amendment that are explicit state rights and have full state authority. One of them is public health. We've been through a pandemic, and people often ask, why wasn't the CDC doing more? It turns out that public health is a state authority in the US Constitution. So we're always going to have that. I mean, we certainly want to be able to say, how can we drive more consistency across those? How can we work with our state partners on better alignment of that? Because I think in the vast majority of cases in a lot of these areas, they do want alignment. Some of them feel the need to get ahead because they're not seeing enough from the federal government from their perspective. So sometimes it's kind of a transition issue. We're hoping that as we move ahead with some of this, that for those states that haven't moved forward with that, they'll sort of be able to look and say, all right, from what's happening at the federal level will be enough to solve the issues that we're trying to solve here. And then perhaps for those who have leapt out ahead, maybe that's an opportunity for alignment. But I think we are always going to live in the US in almost every domain, not just healthcare, where you've got a difference, sometimes differences, and you do have this patchwork problem across the country, for sure.
We're out of time. Do you have something really brief you want to toss out there?
I would just say that, yes, we have this patchwork across the country, but care in Massachusetts shouldn't be different from care in Oklahoma, shouldn't be different from care in California. And so to strive for that consistency so that we ensure that all patients reach the pinnacle of quality and safety of care that we strive for as practitioners has to be what we strive for.
Amirah?
I would just say I agree with that, that I think it is fundamental that any type of AI, any type of generative AI to be used in any sort of healthcare setting, not just medical devices, must go through a rigorous pre-market testing and approval program and must have a follow-up program to monitor it that should come from the federal government. I think that's necessary.
Right. Please thank my wonderful guests, Amirah, Rebecca, Micky, and thank you all for joining us this afternoon for this great discussion. Have a great rest of your day.